I'm Mark Hyde. I'm a PA and the Director of Advanced Practice at the Huntsman Cancer Institute in Salt Lake City. I am a stakeholder in this discussion trying to represent the PAs and NPs in oncology care. First of all, I'd like to congratulate the committee and the organizers for a great meeting. This has been really informative and there have been a lot of great ideas. So from an APP point of view, trying to summarize some of the things we've talked about. First of all, we've established, and we all know, that the rate of cancer may be falling, but the absolute number of patients is not. So we're going to see more patients. We have fewer bodies to take care of those patients, fewer oncologists, fewer staff. So one of the things that I am, as I hear, that I become concerned about is, I think shifting responsibilities to overtaxed team members, other team members that are also overtaxed, is not the right answer. And so the discussions about high performance teams and new technologies are very important, but they need the training and the resources to go behind them. So no, we can't just shift the workload. We need to be more efficient. We need to have the training to do that. I think when we think of APP practice, there are essentially three ways to think about the way that we see patients. This was discussed yesterday as well. There's the shared visits where essentially it's a resident or a scribe model. The APP goes in, sees the patient, the physician then follows them and repeats parts of the exam and then documents it. So you have two people doing the same thing. There's an autonomous model where the APP does everything completely. But I want to define that term autonomous because I like that phrase. I think that the autonomous model does not necessarily mean independent. The APP is part of the team, but they can autonomously see the patient and then bring in other team members as required. And then there's a combination of those two, which I think the majority of APPs fall into right now. The question is, which end of the spectrum are they on? Are they mostly shared or are they mostly autonomous? We saw data yesterday that showed the combination when APPs are seeing patients autonomously, the team of the MD and the APC actually see more patients than if you do shared visits. So I think that it's clear that that's the optimal model. And then we talked yesterday a little bit about, I think it was Brenda talked about nurses coming on, and in 6 weeks they're expected to be proficient and moving, but in reality it can take up to a year. I think that is clearly even longer for APPs, that bringing an APP into the equation, it's going to take a lot of time and investment to get them to where we need them to be. We can make that better through a couple of things. First of all, we can have a better structured training or curriculum, whether that's a fellowship or residency or postgraduate, whatever it is. Within each system, there needs to be structured trainings that will make sure that APPs are brought up to speed so that we can make sure that we're providing a great quality of care still and functioning in an autonomous model. I also think that will reduce turnover. When you look at the American Academy of Physician Assistants data, they say that about 30% of PAs are burned out. And the peak of that is their 5th to 9 year of practice. And that 30% turnover at about $250,000 per incident is a huge cost on the system. When we provide better training, when we provide better onboarding, and then we provide these resources that have been discussed, we can reduce that. We have examples of that throughout the country. I just don't think they're well known. Huntsman has a postgraduate fellowship in oncology as well as a residency in intensive care specific to oncology. I know that there are many other programs that have similar trainings, fellowships, residencies, but there isn't an accreditation system that's uniform for APPs. There is one for nurse practitioners, not for physician assistants. And that could be a very easy, low-hanging fruit to establish some sort of uniform postgraduate credentialing for these programs. So in summary, my three recommendations are, I didn't talk a lot about this, but first of all, to get APPs practicing autonomously, we need to overcome the financial disincentive that currently exists. And Ron just addressed that. If we have a system, any new system we put into place needs to incentivize APPs practicing autonomously. Right now, that is not the case, and so it's not going to change until it is. Second, we need to remove any other barriers that sit in front of practice. So there are a number of laws, rules that currently don't allow PAs or NPs to perform at the same level as the physicians. And I understand that while we're autonomous, we need to be using the physicians as resources, but I think those rules are still restrictive, and those include chart co-signature and restrictions on prescription. And then finally, the formal curriculum-based trainings need to be implemented. There, we might include providing some sort of resource to develop those programs. But I also think that, as we've discussed, that training also needs to go to physicians on how to lead these teams and how to optimize the role of the APP in oncology practice. Thank you.